Welcome to Barcelona, one of Europe's biggest cities and hub for sport, art and now urology. As the 34th annual EAU Congress gets underway, the top minds in urological research and clinical excellence are coming together to discover the very latest science and get to grips with the most up-to-date guidelines and techniques. We're here all week to make sure you don't miss a thing. It's EAU TV. Welcome back to EAU TV and day 2 of the 34th annual EAU Congress. Well, as you can see, I've not quite made it to the theatre yet because it's live surgery day. So I've come to the host hospital, Fundació Pritchford, to take a look at some of the preparations that are happening already. But before that, let's find out what else is coming up on today's show.
You know, I think if you have major surgery and you're a young woman, you want to have as normal a life as possible. And for a long time in women, because it's not as obvious as having an erection, it was sort of neglected that sexual function is important.
Our Department of Urology and Uro-Oncology at Albertine Hospital in Hamburg is one of the most modern departments of northern Germany.
Ultimately, I think prevention based on just blood tests or urine tests should be feasible. And I think that would be the best, the brightest future for everyone and for all the patients.
Our vision is basically to serve poor people at international standard and at an affordable cost with ethics and values.
ARCHES is a multinational or international prospectively randomized study looking at the effect of enzalutamide in hormone-sensitive prostate cancer patients.
You can almost teach anybody to do surgery, but to select the right patient for the right treatment and to follow up, it demands continuity and to be there when the patients are there.
So when we perform en bloc, we want to start marking, delineating the tumor, as you will see shortly.
Well, a busy programme lined up for you for today, but before all of that, let's go behind the scenes at Live Surgery Day and find out just how they make it happen. So, Alberto, where are we here?
All right, so good morning. We are in the OR right now. So right now is where all the setup is and all the surgery will be performed. So as you see, there's a place where we set up all the camera guys and all the videos recording. Go directly to the room where you'll see the robot, which is the new generation robot. If you come in, you will see that these are all 3D cameras. This is our robotic surgery OR, where we do our robotic surgery every day.
What are the challenges of live surgery compared to normal surgery?
On average, the surgeons that we invite for live surgery are superlative surgeons. They are used to this kind of events. But this is not only a surgeon point of view, there's also the team point of view, including the scrub nurses, all the team, the technicians that are not used to the surgeon language. It's really a challenge for the nurses, for instance, to communicate with the surgeon. So that's why we have many people in the room, even a translator.
How do you ensure that the care of the patient remains the same? Are there any challenges to the care of the patient between live surgery and normal surgery?
We are actually giving them the chance to be operated by a very good surgeon. So I would say that we are taking maximal care to our patients. And as you can imagine, it's like when you fly an airplane for the pilots. There are 1, 2, 3, and once everything is checked up, then we start. Particularly when there is a live surgery, I would say that this is mandatory and absolutely 100% secure.
Really exciting to see behind the scenes on Live Surgery Day. And we'll catch up with Dr. Alberto Breda's surgery later on in the show. Right now, let's go back to the Congress.
We want to create an institution which can deliver services at an affordable cost to every member of the society.
The patient has every option, every modern treatment which is available worldwide.
Our vision is basically to serve poor people at international standard and at an affordable cost with ethics and values.
The Wesley offers really the latest technologies and procedures across the range of medical and surgical disciplines.
Our Department of Urology and Uro-Oncology at Albertin Hospital in Hamburg is one of the most modern departments of northern Germany.
Our philosophy is to place the patients first. It's not just a slogan, it's important to all of us.
Well, we're back at the Congress now, and today we're really going to be focusing on the bladder. Everything from bladder cancer to stones. First, I sat down with Professor Morgan Rupre to hear more about immunotherapy for bladder cancer. Where are we with immunotherapy for bladder cancer?
Actually, it's a very exciting time for us as urologists because I would say the new kids on the block for the treatment of medical cancer are checkpoint inhibitors, PD-L1, PD-1, but not only CTLA-4. And for a long time, these drugs have been used in a systemic manner for metastatic diseases. But today, we have seen at the Congress that there were several options and possibility to use these drugs earlier in the natural history of the disease, meaning that the urologist needs to be involved in the treatment of these patients, not only on the surgical aspect, but also on the use of this systemic drug. We were dealing this morning with non-muscle invasive bladder cancer and muscle invasive bladder cancer.
So what are the differences then?
It is very important for us because the vast majority of the people that we see in the Western world are diagnosed with non-muscle invasive bladder cancer. So at a time where all the data are dealing with metastatic disease, there is a discrepancy between the reality of the practice and the trial we are having in the literature. So today, it was stated that there are ongoing studies for these patients with non-muscle invasive bladder cancer because the objective is not only to cure the patient, but to keep the bladder reservoir and to eradicate the disease. So the possibility to use the immunotherapy in that setting is extremely exciting.
What would you say then is your vision for the future for immunotherapy in bladder cancer?
For many, many years, the urologists have been using the intravesical instillation, and we have already phase 1 and phase 2 toxicity trials showing the possibility to deliver these drugs into the bladder. And it will be the full circle for the urologists because we have been using the BCG for many years as intravesical instillation, and we do expect to have the possibility to use these new drugs as an intravesical deliverance. And it will be, I would say, the optimal treatment for the patient because we are facing an endocavitary disease. If we want to have a broad vision of what's going on in the bladder, we need to maintain, I would say, all the treatments, and I think that we have everything between our hands as urologists to take care of these bladder cancer patients.
And that broad vision was evident in the diverse plenary session, which focused on the unique aspects of bladder cancer in the young patient, with co-chair Fiona Burkhardt focusing on the special challenges of preserving fertility, pregnancy and delivery for younger female patients.
I think these young patients who may have a very long survival, it's a very important issue for them to retain their function, and so being able to have children can be a very important issue. Now the problem is that oncology, keeping them, curing them is much more important than the functional issues. So first of all, you have to have a tumor that is placed in a way where it's possible to retain the vaginal wall, the uterus, and all the organs necessary for having children afterwards. And once you have that, the surgery is actually no more difficult than the standard cystectomy. It's actually, for me, I find it even more simple because nerve sparing, which is also important for sexual function, becomes much easier if you can keep the uterus and the vaginal wall intact. It allows you to save the nerves in a more easier fashion.
How important is it taking these considerations with this group of patients?
You know, I think if you have major surgery and you're a young woman, you want to have as normal a life as possible. And a normal life means functioning normally, and that includes sexual function, includes being able to have children. And for a long time in women, because it's not as obvious as having an erection, it was sort of neglected that sexual function is important, lubrication, orgasm. And now increasingly we are becoming aware of these issues, and we are focusing more on retaining function, which is especially important, I think, for these very young patients.
And what outcomes do you find that you have for these patients?
Actually, the outcomes are quite good. So the bladder function is better in these patients than it would be in patients where you do the standard cystectomy and remove all organs. One reason, as I said, the nerve sparing can be done better, and the other reason is that the uterus gives a certain support to the neobladder so that the function is better. And when it comes to sexual functions, the responses I get are quite positive. There's not a lot of data available that really proves it, but when you talk to the patients, they are quite happy. And if they have children afterwards, you would think that sexual function is probably quite intact as well.
Well, we'll have more on bladder cancer shortly. But first, with a focus on technology and the latest techniques for minimally invasive surgery, we're off to the Albertinen Hospital in Hamburg.
Our Department of Urology and Uro-Oncology at Albertinen Hospital in Hamburg is one of the most modern departments of northern Germany. We see and treat over 4,000 patients per year. The emphasis of our department are the uro-oncology, the surgical treatment of prostate, bladder and kidney cancer, reconstructions and neurourology.
The Department of Urology at the Albertinen Hospital is a highly technical department which greatly benefited from the introduction of the robot-assisted surgery, but also the laser applications in the endourology surgeries. You can isolate large amounts of tissue in a very short time. Less operating time allows for faster recovery, which is beneficial for the patient.
The Department of Urology and Uro-Oncology is very well known for its huge range of minimally invasive surgery. We are the first department of urology in Hamburg and surrounding to offer our patients a complete intracorporeal surgery for cystectomy with ileum conduit or neobladder on a regular basis. We provide our patients with a high-quality nerve-sparing treatment during the Da Vinci prostatectomy. We do a systematic whole-surface frozen section approach while our patients are under surgery. We take out the prostate carefully, stain it completely, we send it to the pathologist who reports back to us within the next 20 minutes. So we, as a surgeon, can adjust our approach based on the results.
We are actually located at Hamburg-Eppendorf University Hospital, and we do all the biopsies. We analyze the tissues that come from these clinics. For the frozen section examinations, we have always one pathologist who does the frozen sections there during the surgery. Then we bring them here and we analyze them here and send the results back to Albertinen Clinic.
One of our specialties in robot-assisted surgery is a partial nephrectomy. Where possible, we try to make a selective or super-selective clamping of the kidney. So even with a large tumor, it is feasible to preserve the whole kidney function already during the surgery. With the help of our highly professional radiologists, we receive images to navigate to the tumor vessel securely.
The surgeon has to know about the spreading of the tumor in the body, and he has to know about the perfusion of the tumor. We can easily give him this data in 3D angiograms or even 3D volume rendering imaging. It is necessary to optimize how a tumor can be reached. We can, as imager, deliver this data.
We don't want to do biopsies on patients that don't have prostate cancer. We want to try to avoid this. So we do an MRI of the prostate, which can then locate possible cancer lesions within the prostate and then can specifically biopsy these lesions. What excites me most about working in this hospital is the great deal of interdisciplinary work. We have lots of possibilities to discuss patients, which will then improve their therapy.
The collaboration between the specialties, especially then oncology and urology, is encouraged through the tumor board. All relevant specialties are here. Progress has to take place with people, and people need to talk and discuss, and so they learn together.
With all our robotic assisted surgeries, our patients enjoy the advantages of less blood loss, less pain, low consumption of painkillers, and our patients can leave the hospital very early.
For us, it's very important to offer incontinence services because it gives the patients the possibility to participate again in social life. We have all kinds of diagnostic facilities, urodynamic facilities and uroflow measurement. For stress incontinence, we offer operative sling procedure or artificial sphincter implantation. People have a completely new life when they are treated right, and finding the right diagnosis is very important.
We've been engaged in robotic assisted surgery since 2007. We are the first international Da Vinci training center in Hamburg and the surrounding region for all entities and reconstructions. Many colleagues from all over Europe visit the Albertine Hospital in Hamburg for virtual robotic training and to increase their communication skills in the operating room. Afterwards, we visit our colleagues in their hospitals to complete their training with their own patients. Due to highly demanding settings of the operating room and the complex procedures we do, we focus on providing training directly prior to the real surgery on the patient.
The Albertine Clinic have a young and dedicated team that are really eager to do a good job, and it's great for us to exchange ideas and diagnoses and discuss patients with them.
It's a high throughput department, especially in the urology section. It's a great chance to see lots of operations and do lots of operations, which gives you great confidence in what you do.
In the future, at the Department of Urology and Uro-Oncology at Albertine Hospital in Hamburg, we aim to provide a better evidence base for our treatments, continuously developing our collaborations, science and the practical work in order to get the best care for our patients.
This century has seen a real change in the genomics of bladder cancer, thanks to new technology which enables urologists to undertake next-generation sequencing of huge parts of DNA in one go. Participating in the session, New Modalities in Diagnosis and Treatment in Oncology, Professor Suzanne Asana explained how the data is providing information on prognosis, recurrence after surgery, sensitivity to chemotherapy, or other ways of treating patients with drugs. This is revolutionizing the treatment for patients with bladder cancer.
We are going to look completely different to patients. We used to think in a tumor arises in the bladder or in the breast or in the lungs, so it's called breast cancer or lung cancer or bladder cancer. And with this new technology and the insights that come from the genomics, we will reclassify tumors and thus also patients. And this will result in a completely different approach to patients. So we will really have individualized treatment. Genetic analysis will be used in the treatment of cancer patients, and in particular bladder cancer patients, by examining the tumor of a specific patient. You will then be able to select the optimal treatment for one individual patient. So for instance, at this moment we are considering neoadjuvant chemotherapy in all patients. We will no longer do that because we will learn from this genetic analysis that the tumor of the patient will not respond to neoadjuvant chemotherapy. Perhaps you have to give another treatment modality first. And I think you will get a much better selection, but also a much more optimal treatment with much more efficacy. And hopefully, in the end, we will be able to cure patients, because that's the major goal, of course. I do hope that we will be able to eventually cure patients who come to the clinic with already demonstrable cancer, bladder cancer. or even metastatic bladder cancer. But I also hope that with high throughput analysis from just taking a sample from your blood, that in the near future we will also be able to much more early on detect patients who have maybe already developed quite small tumors, and it's much easier to cure those patients. So ultimately I think prevention based on just blood tests or urine tests should be feasible, and I think that would be the best, the brightest future for everyone and for all the patients.
Well, some exciting progress there in bladder cancer genetics. Now, all this week we're taking a look at the posters here at Congress. So now let's hear from the author of the best non-oncology poster.
My name is Katia Monastyrska, and I am a basic scientist working at the Departments of Urology and Biomedical Research at the University of Bern in Switzerland. Our group of functional urology, works on the molecular mechanisms of lower urinary tract dysfunction. The title of our award-winning poster is Dysregulation of phospholamban and beta-3 adrenergic receptor might lead to detrusor overactivity via SERCA inhibition. We work in close collaboration with the clinic, and we're carrying out a study in benign prostatic obstruction using human patients who allow us to take biopsies of their bladders after urodynamic examination. And we use these samples to conduct transcriptome analysis of the contents of their bladder, which then allows us to link the molecular changes in the organ with the symptoms of the disease, for example, bladder overactivity or acontractile bladders. I think our work is quite important because it helps to understand the mechanisms of action of beta-3 adrenergic receptor agonists such as mirabegron. What we found is that in bladders of patients with detrusor overactivity, there is an increase of phospholamban expression and decrease of beta-3 adrenergic receptor. And also we saw that they have an increase of smooth muscle contractility. The two proteins which I mentioned are quite important because they are regulators of calcium homeostasis, which might explain why these patients develop overactivity. I'm very happy and very honored that we won this award. And although I'm here to present it, of course the credit goes to the teams in the lab and at the clinic. And I feel it as a recognition of our efforts of many years. It's a complicated research, but I think it ultimately can bring answers to the questions we all want to seek answers for.
Well, some great work there, and I'm certainly looking forward to hearing more about that in the future. Now, let's go over to India, where the Rajiv Gandhi Cancer Institute and Research Centre is providing cutting-edge surgery to patients and some highly innovative and soon-to-be published bladder techniques.
The Rajiv Gandhi Cancer Institute and Research Centre in Delhi, India, is one of the largest tertiary cancer care centres in South Asia.
Our vision is basically to serve poor people at international standard and at an affordable cost with ethics and values. We have the medicine department, we have the surgical department, we have the radiation, then we have the support services in terms of lab, in terms of imaging, in terms of nuclear medicine. There's 250,000 footfalls every year, about 23 to 24,000 admissions every year, and we have a very efficient team of doctors, about 200 doctors and all, about 600 nurses. We have about 300 technicians.
The Uro-Oncology department in Rajiv Gandhi Cancer Hospital leads in doing complicated robotic surgery like in post-chemotherapy retroperitoneal lymph node dissection and robot-assisted groin dissection for CA penis. The retroperitoneal lymph node dissection post-chemotherapy has a lot of technical difficulties even in the open surgery, but we have done maximum number of such cases in the world. The groin dissection, is a morbid operation if you do open, but if you do with robotic, the morbidity decreases. And we are number one in the world probably because the incidence of CAPNS is very high in our country, and we do get a lot of cases.
All patients are offered international standards of treatment and care.
क्योंकि यहाँ पर राजीव गांधी हॉस्पिटल में सारी चीज़ें एक ही छत के नीचे उपलब्ध हैं, बायोप्सी और सारी चीज़ें इसकी है, इस वजह से जो है कि कहीं और नहीं किसी के असिस्टेंट पड़े, इसलिए यहाँ पर चूज़ किया था.
The robotic surgery, there was no major cut, no major incision, no loss of blood, but the recovery was much faster. There was not a moment's pain or any agony or any distress of any kind. It was very good post-operative care taken for me. I had the fullest of support of the people here. I very proudly go and keep shouting everywhere, I'm a cancer survivor. Look at me, don't get scared of cancer.
From its inception, the Rajiv Gandhi Cancer Institute and Research Centre has had an integrated research programme in basic and clinical research.
The department has published two original techniques. One is going to get published. One was pitcher spot island neobladder, and this is a technique where we make neobladder after removing the urinary bladder for cancer, and it was modification of existing bladder which was a Studer's bladder, and by this technique the bladder reaches to the urethra from where we remove the original bladder. This technique I am doing since 2005. And we have done more than maybe 1,000 cases. Now we are working on the long-term results of the same technique. The second thing which we published was mini-lap cystoprostatectomy. This is removing the bladder with a small incision. So we started reducing the incision, which reduces the morbidity also of the patient. The third technique which we are working on now is a tube-in-tube technique of joining ureter with the intestine. We have done enough number of patients. Now we are just waiting for the long-term results. Basic research, we had been many collaboration with the ICPO and MET University. I worked in Maryland also in a molecular lab in Center for Prostate Disease Research. Neuro-oncology, we could publish a ERG expression in CA prostate patients from Rajiv Gandhi Cancer Hospital. Those are the only data from India in ERG expression on the prostate cancer. And right now we are working on other projects like maybe prostate cancer genome. The department had been the part of the clinical trials since 2006. We have recruited a lot of patients in these trials. Patient gets benefited because he gets the treatment which is not available in the market, which is free of cost. So we give a care which is not even tertiary, rather a step ahead care which will not be there anywhere in the country.
At the forefront is the technology, and today we have two robotics, various other instruments which are state of the art, be it in radiation or nuclear medicine or PET scan. And in addition, I think the core of in the cancer especially is the diagnosis. We have a state-of-the-art molecular lab, which is one of the best in the country. And through that, we are able to diagnose quickly and efficiently and correctly, because diagnosis in the cancer is the key. Then we have a tissue bank, which is again unique to the institutions. And through the tissue banks, we are able to do a lot of research, and we are able to disseminate this to others also for doing research. We do a lot of preventive free screening of the patient, do about 10,000 screenings every year. And then we find about 3 to 4% are either the pre-cancer stage or the cancer stage. These people are helped by the institute. And in addition, we have a home care unit which goes to all the patients who are at the end of their life, palliative care basically. And in addition, we do a lot of philanthropic work from the hospital because we are no profit organization. We spend about $1.5 million every year on philanthropy work, giving free bed to a patient or giving some concession in the medicines. It goes a long way, especially in the country like ours where people are poor.
Now it's time to hear about another major trial and put one of its authors through their paces. Today, Professor Arnulf Stenzel will present the ARCHES trial to some of his peers as part of our daily feature, Trials on Trial.
ARCHES is a multinational or international prospectively randomized study looking at the effect of enzalutamide in hormone-sensitive prostate cancer patients, which have either been diagnosed de novo as metastatic disease or did undergo primary treatment, either curative or systematic. The study did include patients also that had prior docetaxel chemotherapy. For example, according to the newest data, that docetaxel together with hormone ablative therapy does have a benefit in at least some of the patients. And patients did have in all these subfractions, whether it was geographically or volume related or Gleason score, a benefit in the radiographic progression-free survival.
I think the obvious question that we both had actually is, why did you choose or not overall survival as a primary endpoint?
You know, with more and more initial disease progression-free and overall survival belonging treatment becomes available, then the overall survival really takes a long time to be valid data. So we need, especially in the upcoming additional possibilities of treatment, to have a surrogate for overall survival. And the other thing is, after the treatment with, for example, enzalutamide, additional forms of treatment are available and are used. So then overall survival will also be falsified by the additional forms of treatment.
Where do you think enzalutamide sits in relation to abiraterone?
The additional data which I think are quite good is that the prior treatment, although in a smaller number, curative treatment or attempted curative treatment with radiotherapy or prostatectomy also did show actually no difference with regards to a better progression-free survival, but it also showed that it even was beneficial. You may argue that could have been a bias, but definitely the primary treatment did show a real benefit as well.
If based on this data or data to come, enzalutamide is going to be approved in this castration-sensitive metastatic setting, where do you see the role compared to abiraterone?
The obvious ones, you know, there are side effects in one or the other. It's going to be shown with the overall survival data, which eventually will come out to be the better one. And it's also, again, the sequence, you know, it's which sequence makes it better. And I think we don't have a real answer yet for the castration-resistant prostate cancer. It's going to be taking a long time till we have it here. A lot is also patient's preference, you know, do they like the early morning dosage or do they go for the late night TV doses?
My final question relates to side effects. One of the perceived side effects with enzalutamide, which we see clinically, is fatigue. And the incidence of grade 3 fatigue was relatively low in this particular study.
Again, it's the fitter patient. The hormone sensitive definitely is fitter. And you know, if somebody goes for years androgen ablation therapy, that causes fatigue in itself, you know, and we know that there may be problems to other organs like brain and heart in the long term. So that in combination with another drug that may, of course, increase that fact, definitely will lead to a higher rate of fatigue. I think we'll see that all over. And you see that in the placebo group. In the placebo group, you also have fatigue. I think that's the only answer I can give right now.
Well, we're back now in our studio to discuss a challenging issue in urology. We're looking at when things go wrong. Gentlemen, thank you both for joining us. Bertie, I wonder if we can start with you. You're a medical lawyer. Can you give us an example of when things do go wrong?
We've just done a session in which we looked at 3 specific cases. One was a generic problem, which is when urologists fit a stent, very often for other specialties, and then it gets forgotten and it's left until it's encrusted, and then it's very complicated to get it out, and sometimes things go very badly. Another was where they failed to recognize that a patient had developed sepsis. But all of these are cases where people are trying to do something very specific. They're very highly trained to do a simple job. And in retrospect, when you go back over it, you can see that there were things that they should have done either in the imaging or the infection screening or the prophylactic antibiotics, whatever it is. But above all, what I think is most important about this is that people fail to recognize the deteriorating patient.
From the medical perspective, why are people failing to recognize that?
We fail to define the patients who are at risk. At least that's very important, even before we do our treatments. Of course, we as urologists, we want to heal our patients. We want to do good. And when things go wrong, it affects us tremendously. Recognizing when it goes wrong at a very early stage, but also initially defining patient at risk. That's very important.
Would either of you say that the way that the medical profession is organised has any impact on this?
Doctors are now very highly trained to do specific interventions, to do specific procedures, and 90% of the time it works very well. Because of the way in which medicine is structured, with shorter working times, with patients in the hospital for much shorter periods, doctors have, when they're in training, very short interventions, and the trainee is just there as a fleeting acquaintance who comes in to do a specific job. And when they are complicated, they meet them for the first time after they've had a complication. And then those patients mostly do well as well, because the complication is skillfully handled by the consultant and the trainee is a spectator.
Technological development has moved tremendously forward in our specialty. We are doing more and more procedures, minimal invasive, and many of the procedures it can be done as a single surgeon. When I was trained many years ago, we were assistants to the seniors and seeing the procedures many times. For the sake of productivity, the younger doctors are put in another place in the organization to earn their money.
So the younger doctors aren't gaining the experience that they maybe would have done a generation or so?
Certainly, and it's partly because we're more risk averse. We don't allow juniors to do things.
Paul, what do you think we can do to rectify this?
You can almost teach anybody to do surgery, but to select the right patient for the right treatment and to follow up, it demands continuity and to be there when the patients are there.
And more rules. That's what the cases we were talking about this morning were about the rules that there are to protect the doctor and the patient.
Great. Well, thank you both for joining us. Obviously, we could talk about this for all day, I think, but have a great rest of your Congress, and thank you for joining us.
Thank you.
Well, earlier we caught up with Dr. Alberto Breda as he prepared for a day of live surgery. Now it's time for him to show off some of his skills. Let's go and see how his bladder tumour resection is going.
So when we perform en bloc, we want to start marking, delineating the tumour, as you will see shortly. The nice thing of the en bloc with this loop is that we can go all over around the tumour and delineate all the tumour. You see, I see the fiber of the muscle in here, so I can decide at this point and at this particular moment whether I'm happy with this muscle or I want to go deeper.
I have never worked with that kind of loop before, the rectangular loop, so I found that really interesting. I think, well, of course, he's very fast, has a good technique, so something to learn and watch.
We have seen many different options, kidney stones, BPH new treatments, and etc. So the vision has been very good, the techniques
very interesting. It's making yourself think about what you're doing and how you can be better. And I think this is something that is pushing you forward.
When you see new techniques displayed, you hear from the people that are using it firsthand, and you get an idea if you can use it in your own department. It's very good.
Well, that brings us to the end of today's show, and I think we are definitely up to date on the very latest about the bladder, from cancer in young patients to genetics and stones. And if you missed anything, don't worry, there are plenty of ways to watch. You can watch in your hotel room, in select hotels, online, and of course here at Congress on the big screen behind me. We've got another busy day in Barcelona lined up for tomorrow, when we'll be focusing on the kidney. So get some rest, and we'll see you tomorrow. Bye-bye.